All right. Well, good afternoon, everybody, at least everybody on the East Coast. It's Friday with NFQF, so we're trying to edutain you in the area of health. Sorry. Franny Garrett, I'm the CEO of the National Minority Equality Forum, and we have a very special panel today on a topic that you've probably heard a lot about over the last, I'd say, few months on Most Favored Nation. And we're going to explore what that means. I'm going to turn it over in a minute to my boss, Dr. Gary Puckrein, who's going to introduce you to the panel. But before we do that, I want to make sure everybody has logistics. So if you have a question that you want to ask, please put it in the Q&A box that has a question mark below the screen. And if you just want to chat and keep the conversation going, I'll put some statistics that you're familiar with. Please put that in the chat function. But turn it over to people that are far smarter than I am on the topic. And let's start with Dr. Gary Puckrein. Dr. P.
Yeah, thank you, Brandon. Welcome to everyone, and thank you for joining us on this important conversation. Before we dig into this discussion, let me try to set the stage a little bit today about our topic. So I always confess all of my sins before I start anything, and I have to say, I am not a fan of government price controls. And one of the things that we're going to talk today about is a government price control called Most Favored Nation, or MFN. You've probably heard a little bit about this, some recent negotiations between the government and pharmaceutical company. I thought it would be helpful to make sure we all understand what MFN means and what this proposal would do. I want to set it up. I always like to spout a few numbers to give us some context. So in the US, we spend about $4.5 trillion a year on healthcare, $4.5 trillion a year on healthcare. In France, the gross domestic product of France is $3.2 trillion. In Germany, it's about $3.4 trillion. So their economy is a lot smaller than ours. And so what we're talking about is setting American prices for medications against countries, whose economies are smaller and which have a tendency to restrict access to medications. And so, in effect, what we're talking about is these countries who don't have open access to all medications, us setting our prices along their lines. And so this is government price control, and it comes with a lot of implications. Questions that we need to answer before we try to put those policies into work in our country. Policies like, would community-based providers be able to stock and dispense medications? Will individuals have to travel long distance or incur higher costs by seeking care in hospital settings? Probably one of the biggest challenges for me is really the impact on research and development. Whether you want to appreciate or not, profits and R&D spending, research and development spending, are closely aligned. And so we are in the middle of a medical revolution. We are doing amazing things and treating diseases that heretofore were essentially untreatable. And now we want to slow that down by putting a program in like MFN. And then there's the challenge that we think a lot about at the National Minority Equality Forum is the impact on minority and vulnerable populations who already face challenges. And at the end of the day, MFN is really about saving money, if you will, in the crudest sense of that word. But that's not what healthcare is about. If you think a moment about healthcare, what healthcare is about is keeping people out of the hospital, keeping them out of the emergency room, keeping them from disability, helping to conserve life, and helping people to live high quality, long lives. And when you use that metric, you have to ask yourself the question, is MFN going to contribute to that, or is it going to take away from that? And luckily today, we've got some very smart people to help you understand MFN and answer some of those questions. I'm going to start by introducing them, and then we'll go into some questions. And then following that, we'll have some opportunity for you to ask questions of our guests. So let me start off by introducing Cici Rojas from the Latino Coalition. She's an accomplished businesswoman and advocate for her community. Sarah Van Geertruden serves as Executive Director at the Partnership to Improve Patient Care and brings deep expertise in healthcare policy to today's conversation. And then one of my best friends, Dr. Elena Rojas, who's president of the National Hispanic Health Foundation and will help us understand how these policies can affect patients in the real world. So let me start off with Sarah. Sarah, why is this discussion so urgent?
Thank you. Yeah, I mean, you said it. I mean, and you'll probably hear us all talk about MFN, which is most favored nation. So I always try not to use too many acronyms, and I probably will. So I'm going to apologize in advance. But yeah, this most favored nation policy is big news right now, as I think folks are probably reading about, largely in their newspapers, and it probably seems like a foreign concept, right? Which it is. But the idea is to lower drug costs. But the reality from our perspective is that there's a tremendous risk of importing the kind of discrimination and access restrictions that we see in other countries. So at Partnership to Improve Patient Care, which we call PIPC, we often talk about the risk of relying on what's called a quality adjusted life year. The acronym for that is QALY, QALY. And QALYs are used to determine whether the cost of a medicine is worth it for certain patients. And so these kinds of metrics will define the value of the product. But what we often will find with this measure is that it devalues people with disabilities and chronic conditions, both in the context of how we value their life extension, because a year in the life for a person who is disabled or has a chronic condition is considered to be less than a person who is living in optimal health. And that's part of the calculation that goes into a QALY. But it also discriminates in the context of quality of life improvement, because the way that quality of life is defined is often through these sort of very biased public surveys that feed in then what's called health utilities. And the long and the short of it is that how it's measuring quality of life and quality of life improvement also works against people who are living with a chronic illness or disability that isn't necessarily going to be cured. So in that way, the metric inherently discriminates, yet it is a metric that was created for the purpose of valuing healthcare and is often used by other countries to ration or restrict care. So we're very concerned about how we might be then referencing other countries who very explicitly rely on this quality adjusted life year or QALY measure. Because it was created in the UK for the purpose of rationing care, right? And so this doesn't seem like a concept that we would want to bring here to the United States. So it's I'm just appreciative that we're having this discussion now, because I do think that for a lot of folks, this is a foreign concept, but we really want to make sure that we're talking about the policy without ultimately ending up with the kind of restricted access we see in other countries for these populations.
So it's worth saying again, Sarah, that embedded in MFN are all of these quality restrictions.
Yes.
That we would be importing.
Yes. So most other countries use QALYs as a benchmark for how they price healthcare, but then so they'll say you can get this if it's cost effective. It's cost effective for you based on this, what we've defined as the QALY-based price, right? So when we import those prices then from other countries, what we're importing is how they use these QALY-based cost effectiveness analyses to their structures. And then what we're doing now then is talking about importing those here into the United States, which ultimately puts us at risk of the same kind of discrimination that goes into how they price and cover and restrict access to care.
Right. Thank you so much. I want to ask each of you to discuss how MFN could impact the communities you advocate for? So I'm going to start off with Dr. Rios.
Mhm.
Mhm. So how will MFN impact the community that you advocate for?
Well, you know, for the Latino community, they've historically had lots of access issues. Number one, they're the largest ethnic group in the country without health insurance, even with the Affordable Care Act, because of applications, because of language, because of just working all the time and not caring about going to apply for insurance. I mean, just not even understanding what insurance is. So there's a lot of education needed in our communities, but many Latinos not only struggle with insurance, but there's also the financial barriers just to get to care, you know, having access for childcare, transportation. So lots of access issues, and I have to say that the MFN policies just exacerbate access to care because they're going to, you know, it's already been shown, and Gary already mentioned it, that it is about looking at medicines pricing and that can cut out the opportunities for Latino families to get access to these especially new drugs that are a little bit more expensive, but they're cutting edge medicines that actually cure diseases. I mean, I remember when Hep C, the drugs for Hep C came out. Oh my God, they cured liver cancer. And now we've got drugs on the market or about to be on the market that are going to really decrease cholesterol and heart disease. And we've got all kinds of cancer opportunities now with new medicines and new therapies. And it's going to hit our communities even harder. So it's really an access problem. And then for providers, healthcare providers, doctors are always complaining about access issues because they want to take care of their patient. They want to see their patients get better. And having to choose between optimal treatments to patients and actually staying in business, having patients come in. Our clinics, our hospitals, even our academic health centers are all based on the money that comes in from patient care and patients. People don't realize that, you know, healthcare is a big business and we need access to care. But in terms of our, I'll just say for oncologists, they're especially worried because of the reimbursement for cancer therapeutics that would be so significantly increased if we go the route of these horrible policies, this price setting that's going to delay launch and development of more treatments that can impact our underserved communities even more and have more toxic stress. And that it's a cycle. We'll have a cycle of more diabetes and more cancer and more stress and anxiety, even not just the patient, but the families that have to care for them when they can't get the medications that they need. So we need policies that make medicines more affordable, but also available.
You know, as I was listening to you, I was struck by the fact that there is a little bit of math here in the sense that what healthcare is really about is reducing risk for patients, right? Not elevating risk. And what I hear you say is drug pricing programs like MFN can elevate risk, which is the opposite of what healthcare should be driving to accomplish. Am I right in that?
Mm-hmm.
Right.
Definitely.
Yeah. Cece, how do you think MFN will impact the community that you advocate for? You're on mute, Cece.
There we go.
Okay,
As someone,
thank
I wear a lot of hats, but you know, I've I'm a cancer survivor, and even though it's been a few years now, it's still really fresh. And it was thanks to access to a treatment that I received through a clinical trial that I know firsthand how crucial it is to be able to get the right, you know, medicine at the right time. You know, MFN could mean that the newest, most advanced therapies could be harder to get. And I'm also a business owner, so I've firsthand experience with purchasing group insurance and having to shop around for a good and affordable plan for my own employees, for myself. And I'm going through that process right now, as a matter of fact. And, you know, as a business owner, I want to be able to provide good, you know, good health coverage for my employees. That's something I think any employer would want to do. And Latinos are the fastest growing segment of small business owners. So, I mean, this is something that weighs heavily, not just on me, but others. So, having access to the clinical trial, though, and insurance to help cover my care was critical for me. So I'm very concerned about policy changes that can make it more difficult to provide those benefits. We need solutions that will lower costs and increase access. I mean, back to Dr. Rios's point, it is all about access. And the policy that we don't need to look at policies that are going to risk shutting the door on innovation and hope that our families and our communities need.
Cece, I really appreciate what you said as a business person, having to buy healthcare in the marketplace for your workforce, but recognizing that you want to buy quality, that you want to make sure that the product is actually going to contribute to their well-being. So as opposed to just a raw financial decision, I think that's absolutely commendable. Sarah, how about your community? How does MFN impact the community that you advocate for?
So, I think it's important to back up a little bit. So the disability community has a very long history opposing the use of quality adjusted life years, in large part because of what we've seen in other countries, right? So at Partnership to Improve Patient Care, we have a significant focus on this idea that you're going to devalue disabled lives as part of the measure of what we would determine to be, I'm going to put quote unquote cost effective, right? Based on what some academic says in a study. And our coalition is led by Tony Coelho, who wrote the Americans with Disabilities Act. So as you can imagine, this is a significant priority for him, because this is his ministry, and his mantra in life is, nothing about us without us. And it means a lot to him. But, when you're using the quality adjusted life year to create sort of this one size fits all measure of what is valuable, right? What you end up doing is kind of sidelining communities that don't fit the average, right? And there's no nuance to understand that different people will react differently to the same drug or treatment, right? Which is what precision medicine and personalized medicine is all about. So, I mean, we are a country, though, that has a history of sort of pushing back on these kinds of policies. So, some of you may remember in 1992, the state of Oregon actually tried to get a waiver to use quality adjusted life years to rank its prioritized list of services. And HHS said, you can't do that. The Americans with Disabilities Act had just passed in 1990. And HHS at the time said that would violate the law because, it came up with some really wacky what would be covered and what wouldn't, right? So treatment for spina bifida, which had terrific treatments at the time, would not have been covered under that because of the quality adjusted life year. And then later in 2010, right, with the Affordable Care Act, Congress said, we're not going to allow the use of QALYs in Medicare, right? Well, that was terrific. So now Medicare cannot use a QALY to determine coverage or reimbursement. And then last year, a Republican House passed a bill to extend Medicare's quality ban to all federal programs. So I think on a bipartisan basis, we've made a commitment in this country not to rely on this kind of measure that is known to discriminate. And yet, that's exactly what we're doing by importing them from other countries. And the risk and the reason that the disability community has been so vocal in advocating against it is because of the implications it has for them because of what they see overseas in terms of how care often gets restricted and rationed against populations like theirs. So it's a concern.
Mm-hmm.
Well, Dr. Rios, I'm going to return to you for a second because, the reality in minority communities, and we don't say these words out loud very often, there's a lot of rationing of care that goes on in our community. We do in fact have a tiered healthcare system that we are constantly advocating in the same way that Sarah is advocating with the disability community. We're advocating for the minority and vulnerable communities. I think of rural communities, for example, and the challenges that they face as well. So can you talk a little bit about the advocacy work and the need and the recognition that MFN is just going to come in and exacerbate the problem that we're trying to fix right now? Because when we look at the data, what we see is that, and we call them underserved communities because that's in fact what we're doing with them.
Yeah, I think there's a lot of advocacy that we can do, and especially from the providers that we work with who see patients all the time and have the stories of real impact of lack of medication and losing, uh, opportunities to continue treatment for cancer or for diabetics once these MFN type policies would go into place, if they should go into place, which I think shouldn't. But I think for our minority communities, especially, there's so many high costs already in food and gas and now the electric cars that were supposed to have rebates aren't going to have rebates anymore. I mean, insurance subsidies are not going to be passed, or at least that's part of this government shutdown negotiation. That means all the premiums are going to go, double and triple. So there's so much cost pressure on families, and especially young families. We've got elderly people that are taken care of by their adult children, and then you've got these adults taking care of young children, and they're just trying to live check by check. So, in the disabled community, the same. It's just horrible, the idea that you would just limit more access because of price controls. Um, I think in terms of advocacy for policies that would allow more people to have affordable medicines, not talk about increasing pricing. And the affordability is in for pharmaceutical companies, for example, they offer patient assistance programs. The federal government has a longstanding program called 340B program that offers lots of opportunity in hospitals and clinics that sign up for the program to offer patient discounts. Now we know that there's reform needed because there needs to be more data to show that the patients actually get the discounts and that there's not all these different middlemen that we know about in different healthcare policies. So we need to get more I'm going to say more programs for pharmaceuticals that are creating affordable discounts for the patient at the site of sale, and not talk about raising all these prices and not having access to medications. And I think we actually need more investment in our community health centers and culturally competent care, language services. We need a more of a bilingual workforce, even if it's not just Latinos talking to Spanish or Chinese people talking in their dialects. We just need to have a better handle on communication. And we also need more patient navigator and education. There was a whole focus on community health workers when the Affordable Care Act happened, to have more people educate our communities about how to apply for drug treatment programs or, and I don't mean drug substance abuse, I mean programs that are there to help you get the drugs or the insurance or the healthcare navigation in these systems that are very complex. How to get to the X-ray or the MRI, and then go see your primary care doctor and then get a referral to a specialist. I mean, it's like the old what is it? Oh God, I can't even think of the name of the games we would play, where you'd look for the treasure, or I don't know, all these maps that are clearly not understood, and now everything's on digital, and we have this huge digital divide. So anyway, I know I'm getting off track, but I think that it's crucial that we have policies that promote innovation, new treatments, and treatments that are affordable, and providers have access to the knowledge about the new treatments. And of course, they don't give treatments that are going to cause side effects with other treatments. So we have to really make it easier for our communities of color and our disabled communities to get the medicines that doctors prescribe and that are needed, and not stop medications from getting to our patients because of these uh, outrageous policies.
Yeah. I think what you were saying, if I may summarize, is that a healthcare system needs to be reimagined for sure, particularly as our country becomes more diverse and has to meet the challenge of providing quality care to diverse populations. And access should be front and center on the table in terms of conversation. But MFN is a blunt instrument. It is not going to solve any of that. So you just can't say, oh, let me just take this particular MFN hammer and take a whack at the system and expect to come out the other side with something that's delivering quality care. When, quite frankly, our healthcare system was built in the 20th century. We're in the 21st century now, and we need to think about 20th century
Yeah,
solutions, 21st century
definitely.
solutions. I think that's where you're going, and I think that's what we're all collectively advocating for.
I got trained in small area planning when I was in public health school. And then Governor Reagan became President Reagan and abolished it because he wanted to foster the importance of managed care. They were in the same law. But now we're coming back to this. The states in this country are going to have to pick up the slack. And I don't know how much of federal policy is even going to be worth it if without a federal health system. Our federal health government is being slashed. And I mean, that's not the topic of this, but it's just in reality, we're going to have to rethink. You're right, Gary. We're seeing the beginning of a rethinking of what healthcare delivery should be that makes sense for our communities. And we definitely need the best and the innovative medicines that'll help our communities live longer in quality lives.
Mm. I'm one of those, my deep prejudice is I want to go faster. I want more innovation. I want to
Yeah.
get innovation spread out to the community. I don't want to recreate the 20th century where we don't have the products that we need to actually extend life. So that's where I lean in on. We have to do this in a lot smarter way, and taking these blunt force instruments are not probably going to help. Speaking of innovation, CC, you were involved in a clinical trial. Tell us a little bit about that experience.
Mhm.
Sure. So back in 2017, I got the devastating diagnosis that I was diagnosed with stage 4 lymphoma. And anytime you hear those words, it literally turns your world upside down and you think about your life very differently. But, first I just chalked the symptoms up to being just busy, burning the candle at all ends. But then I knew something was, really, really wrong. It was a rocky road. I underwent 6 rounds of, standard of care chemotherapy at the University of Kansas Cancer Center. And then my cancer did go into remission. But about 7 or 8 months later, it did come back. And this time, my docs told me that, I could go directly to a bone marrow or stem cell transplant or participate in a clinical trial at the time. And it was pretty breakthrough therapy called CAR-T. And I was number 5 at the healthcare system to go through that process. It was daunting, but it was an exciting opportunity for me. There was never any doubt in my mind that I should participate, and I encourage everyone I come in contact with, when they get a diagnosis like that, to ask about a clinical trial. And it was a new trial, and so I felt like if it could help me, it could certainly help others, and of course, science. So I knew it was important to do it. And the clinical trial did save my life. What it did for me was it got me to a point of remission again, and because I did relapse from that clinical trial. So I went through it a second time. And at that moment, it was more about getting me to a point where I would be cancer-free so that my chances for survival and my outcome would be a lot better for a bone marrow transplant. And that's what happened. But the clinical trial literally saved my life because it got me to a point where I would have a better outcome. And obviously this was just a product of, the investments and commitments made to innovation, research. And so for me, that meant that was the difference between, survival and it being terminal.
Well, first of all, I want to thank you for telling your story and the courage that it no doubt took to participate in a clinical trial, and the contribution you made, because as a participant in the trial, you sort of helped bring those medications forward, and I'm sure thousands of lives have been saved as a consequence. We also need to underscore that clinical trials ain't cheap. They are very, very expensive to do, and sometimes, probably closer to more often than not, they don't work as we would hope they would work. And that's the investment that innovative companies make. They spend a lot of money to bring these new medications forward. And to me, it's part of the free market. It's what the marketplace does. It sees an opportunity to bring value, and it brings that value into the marketplace. And our challenge is, how do we make sure that that value gets out to everyone? Because those CAR-Ts are not accessible in the minority community in the way in which they should be. We see tremendous disparities in there, and what that means is those folks die. And MFN is not going to cure that, right? And that's the point we're making, is that we are encouraging our community to participate in clinical trials. We want them to do that. We want these innovative medicines, but we also need to think creatively about the access issues to make sure that the value of what we're creating gets broadly disseminated. And when you look over in other countries, they don't have that same sort of commitment as Sarah was describing to everyone. That's not where we want to go. That's not healthcare. That's not anything that we should sign on to. And that's where the advocacy is going to be so critically important as we try to move forward here. So, Dr. Rios and Sarah, what are your solutions? What do you think about as we think about this ecosystem? What can we do to? And I know this is out of all of our pay grades, because we're talking about this gigantic healthcare system that we need to think about. How do we reimagine? It's all balkanized. You got so many moving parts all over the place, and quite frankly, a lot of people dipping their hands into the till who are not bringing value. What's your sense? What can we do here? Sarah first.
Yeah, I mean, thank you. I mean, first and foremost, I mean, I don't want to replicate what we're seeing in other countries. I mean, some of you may have seen, we have this video that we just put out about a Canadian family with 2 kids with Wilson disease, and just the stories of how slow their access to care has been. And same thing with cystic fibrosis, right? I mean, we're seeing across these countries that we're trying to reference how delayed their access to care is. And when we talk about affordability, right, I think the thing that I think people may be missing is that this is not going to necessarily promote affordability, because when you're looking at healthcare in a way that is discriminatory, you're actually going to then create a justification for restricting access to that kind of care, which just makes everybody's care more expensive when they have to do it more out of pocket, because now we're relying on these kinds of discriminatory value assessments. So I want to just make sure that that affordability point is made. But there are a lot of policies that Congress is debating, because the utilization management issue, I think, is really what's driving a lot of the affordability challenges in this country. So I think from my perspective, I wish we were focusing more on that, right? The prior authorization, the step therapy, the fail first kind of things that are happening in the system that too often are based on these kinds of discriminatory viewpoints around cost effectiveness and looking at people as averages and one size fits all. I think the other thing, we've been following also very closely some of the work that the International Consortium for Health Outcomes Measurement, known as ICHOM, has been doing to try to match, looking at high quality care and defining high quality care in the context of what outcomes we're achieving so that we're actually getting value in the system, because that's where you get value, right? You want to match high quality care to good outcomes. And then, in the Affordable Care Act, there was this entire section that we keep forgetting about around shared decision making, where we were supposed to be advancing the use of clinical decision tools that helped doctors and patients make good decisions so they were getting the right care at the right time. And we haven't really been doing much with that. But that's a way, again, to create value and high quality care in a more systematic way. So I think, we really want to see that. I mean, I don't think that any of us here are arguing that there's not waste in the system, but it certainly isn't the kind of high value and highly effective treatments that this most favored nation policy is targeting. So if we really want to get to, wellness, right? What we need to be doing is thinking about how we're getting people the care they need when they need it. And I would say, in the context of this administration, right? I mean, I think we all want America to be healthy. So, a focus on prevention is great. Let's do that. So there's a lot of things we could be doing. I just, I guess in our world, we would argue though that this most favored nation policy is not the place to start.
Dr. Rios?
Yeah, I have to echo that. We shouldn't start with that. I mean, we really need to start with thinking right now as the federal support for research in this country is being decreased. NIH is being decreased from 21 institutes to 5. And the 3 different agencies called CDC, HRSA, and SAMHSA are being slashed by 40% of staffing and grants and programs so that they can be all covered under one new administration called the Administration for a Healthier America. And I do believe that it is important to downsize, especially in this age with so much high, our economy is really going out of whack inflation wise. And healthcare, we all know is a big part of the economy. So we do have to downsize. And it does make sense to look at how we can decrease the repetitive offices within these agencies and put them together. But does it make sense when you want to make a healthier America to decrease all the health education programs for cancer and diabetes and heart disease, which are the chronic diseases that need all these new medications to be able to have a better quality life? So I think what has to happen is we really need to rethink and put patients first. What do we want to do to improve patient care and the education of patients to get to the care that they need? And I know it was mentioned earlier, we need the right medications and the right care and the right providers in the right places. I think one of the biggest problems we have is rural health care. And our rural clinics and hospitals are already closing because they know patients are going to be horribly treated by these new policies such as MFN or policies that are just decreasing Medicaid, so that there won't be people, and then the people that are healthy are going to stop insurance. So insurance premiums will go high because you're going to be taking care of really sick people. So I mean, everything points to how we need better access to better medications.
I'm going to be a little bit of a contrarian in this regard. So my doctor's actually in history. I should have confessed that at the beginning of this conversation. And I studied Hippocrates, Aristotle, and Galen, bloodletting, leeches, and God knows what all that didn't work. I studied before we had antibiotics, where we didn't know how to control bacteria infections. And now we are at the moment where we have a test that can predict Alzheimer's 10 years before you
Wow.
actually become symptomatic. We have diagnosis for 50 different cancers at one stage. We can look at Parkinson's disease by blood exams and know even before you're symptomatic, your risk for Alzheimer's disease. And what that is signaling is that we are moving to early onset. We are moving away from symptoms and actually being able to see the onset of the disease before it's bringing changes in the body, irreversible changes in the body. That's the revolution that we're after. And you're telling me I want to shut down NIH? You're telling me that I want to close down CDC? You want to do what? And now you want to import MFN? You know that's crazy, right? You know, I'm sorry, I got to call it what it is. This is not the moment for that. We are in a moment where we need to put our foot on the gas. We can help so many Americans. We do a lot of work in communities where people have a high elevated risk for cancer. We can bring those innovative therapies into those communities and give them access. Why wouldn't we do that? I mean, I don't even understand what the conversation is. I don't understand what our members are talking about. They're all in the 20th century. We need some 21st century folks in our government who have some idea of where we're going. I'm sorry, and this is like both sides of the aisle. You guys, I think Sarah mentioned it. I remember it was Elena mentioned it. It's a war. And you have to bring your best troops to war. You have to build the logistics and the infrastructure. And I don't hear any of that in this conversation about MFN. I hear people who, in fact, I just don't even know what they're talking about. I'm just being really honest. I don't know how that fits into our future when our future is in front of us. We can see it. We can do so much with it, and we're not taking it on. So I'm going to open up the lines, and if you've got some questions, put them into the chat, and we'll try to get to some of your questions. But as people are thinking about that, I'm going to go back to Dr. Cece and talk a little bit more about your vision. You're actually buying healthcare. You're the one in the marketplace having to negotiate. What would you like to see happen in that marketplace?
Well, I mean, obviously, it's a very complex issue. I think, but there's some basic things like we know that, for example, my company, we do a lot of work in the healthcare space. We work with cancer centers on education, and a campaign we're working on at the moment is around, the tie from of obesity to 13 forms of cancer. And so, what if we know that by lowering the risks or lowering or helping people with behavior shifts so they can, they can be at a healthy weight. And if that's one thing we can do, so how can we lower the access barriers to the drugs now that are making it possible for people to, lose weight and be that have a better fighting chance if they do get the diagnosis that they have cancer. So, I mean, things like that would help a small business be able to provide some of those preventative type of therapies would be, really, I mean, I would think would be very, that would help me, obviously, with, when I'm looking at insurance for my employees. I think the other thing we could do is also just, talk to our communities, talk to our networks, and make sure they understand, what's at stake here. I think many people just don't it's not top of mind for them until it hits their wallet, and it's like, what do you mean my premiums are going up 18 or 20%?
Yeah.
And I think the important topic we haven't even touched on, which is fine, is that there's an economic accelerator proposition here for CAR T, for example. Now it's a standard of care. Our cancer center here, we are building a lab That one, you got to construct it. We're going to spend they're spending millions and millions of dollars to develop a lab that is now going to produce CAR T. And then now we're going to become a hub in the Midwest for distribution. That's going to take people and jobs and, all of that. So there's an economic accelerator here that, we've really not even touched on. So I think that the business community can be helpful in making sure that these messages get out in a way that is going to impact these business owners and drive them to advocacy, and to activate their relationships with elected officials. So I think that's what I would hope would come from some good education.
Mm-hmm.
Cece, you have touched on something so incredibly important that is really poorly understood. Everybody thinks that healthcare is just the cost, and they don't see it as part of our gross domestic product, that it's part of our business, that it hires people, it employs people, it creates value.
Right.
And really, the point is, as you were suggesting with the GLP-1s, which are there, can help with obesity and the onset of cancer and all that. If you get down to the zip code, you've got some communities out there with high prevalence of diabetes.
Absolutely.
That impacts workforce, presentism, and a whole lot of other things. If you could get those folks treated, you'd make a better workforce. You would strengthen the local economy. I'm just sorry, but there are business solutions here that are incredibly important, and it's just not all about cost. It's about investment. It's about building out to the future. And I think that's what I talk about when I talk about free market, is to let the marketplace pay, as opposed to having government bureaucrats sit in the back of the room, pumping out policies that are not associated with the realities of the ground, and really creating just tremendous problems because of the access issues and things like that that they promote. So I want to thank you for bringing that business sense to this conversation, because I think it's incredibly important. Okay. So, as you can hear, from the National Minority Quality Forum perspective, we're thinking about the future of healthcare in this country. We think about an antiquated system. The Medicare is now turned 50. Medicaid is turned 50. Do we want that system for another 50 years? Will we get down to 2075? Is that what we want to? I don't think so. You got more economists sitting over there at CMS than you got doctors. I mean, I'm not sure that that's what we need. And so I think conversations like this, I think MFN should trigger a national conversation about what's our future in healthcare. What is it we actually want? How do we take small steps and bites to get there, as opposed to having these sort of sledgehammer conversations about, I'm old enough to remember, I don't know if you remember the Sunshine Act. I don't know how many of you remember that, in which we were going to solve the cost of drug costs, because we were going to have the sunshine provision, and all the companies are going to have to tell what pencil they gave to a doctor and send that up to the federal government. We haven't even repealed that mess. And I dare say I don't even know what the bureaucracy looks like, that everybody has to now send to the federal government some documentation about, well, I gave a physician a pencil. But you get my point, that these one-off sort of ad hoc conversations are really not constructive. And we really need to take a step back and think about how do we provide for a diverse community. When I look at California, California is diverse. When I look at New Mexico, it's diverse. When I look at Arizona, it's diverse. When I look at Georgia, it's diverse. When I look at Maryland, it's diverse. I'm sorry. Um, this is a different America, and it needs a healthcare system to take care of all of this diversity and challenge that we have, and we keep trying to preserve what is not preservable and shouldn't be preserved, which is a healthcare system that was born in a different age and is having trouble dealing with innovation. And how do we provide innovation to a diverse America? Anyway, that's how we think about it from the National Minority Quality Forum's lens, and in some way, I'm not going to call it a constitutional convention, but we need to get a group of people, advocates in the room now, and say, okay, we've had enough of you guys. Let us come together and think about how we assemble something that makes sense for the community. We work in the community. We're down in the ground in the community. We hear the suffering. We hear the decisions that people have to make about getting access to care. We hear all of the defenses about this particular policy or that policy. But when you look at what's actually happening to people in community, they're not getting the healthcare. And then finally, I would just say, of course, it's our money. Every nickel, penny in the American healthcare system, that $4.5 trillion, that comes from every American household, every American business is contributing to that pot of money. And I think, we should have a say in how that money gets spent. And I don't think MFN gives us that sort of conversation. All right, so we're getting close to wrap up. So I want to give everyone a chance to talk a little bit about MFN, to think about the future, think about advocacy, where you think we would go. So Sarah, if you don't mind, we started with you. So if you don't mind, I'll ask you for your thoughts.
Thank you. I appreciate it. Yeah, I mean, I think, like, for us, this really boils down to how do we advance informed decision making and access to care, and I understand the affordability challenges, and I think that the challenge though is, and this is why when Congress was thinking about doing an MFN model as part of reconciliation with Medicaid, right? They didn't go down that path initially. Why? Because it actually wasn't going to make anything more affordable. And I think people on both sides of the aisle recognized that. So we are now walking into, considering these policies across the board. And, I know there's very little detail out there about it, but I think all we can speak to, and it's the same thing that the National Council on Disability, which is an independent federal agency, has spoken to, is that if we start to look to other countries to reference the policies that go into how they do things and we bring them here, we are essentially risking incorporating the same kind of discrimination and rationing that they do. And so, I think this, for us, it gives us pause. I think there are a lot better ways to get to a more high quality and affordable healthcare system by addressing the root cause of affordability challenges, which tends to be the utilization management process, because we all know that prices are, the list price is not the price, and then everybody's paying these different prices. And I understand that, but like, if we really want to get to the root issue of how we get value into the system, it's got to be about informed healthcare decision making, where patients and providers can get access to the thing that they know is going to work, or that, that has the most evidence of working. And so that's really where we are. That's where PIPSI is. And I do think that Dr. Puckrein, I mean, we always love having these conversations with you, because I think we're all on the same page. And And if we put our heads together, we should be able to figure this out. But
Yep.
anyway, thank you so much for having me. This was excellent.
Sarah, I love what you just said, and I was saying to myself, because I avoided saying it out loud, when we talk about a drug price, there's so many characters and hands in that pie that, we in this particular webinar, we're not talking about, because everybody thinks that 100% of that dollar goes to the manufacturer, and I'm sorry, that's not what's going on here. And there's a lot of history and things that added to all of those costs that would be interested to see how MFN is going to tackle any of that mess. But I think sometimes we don't have a full understanding of what goes into the price of a medication, the politics and everything else that sits in that cost. And so I said to myself, well, Sarah opened the door, but I'm not going to go down that hallway with her today. We'll find another time to talk about that. But it's important for this group to know, who are listening to us, that there's a lot that's going on in the price of a medication that we're not talking about here. Dr. Rios, as you close out, I'd love for you to say a little bit more about workforce and MFN, and because I know your life work has been around workforce and making sure that we have a diverse workforce that treats all Americans, and I don't see MFN as a solution for anything that you've been working on.
Oh, definitely. I think the MFN access issues are so important, policy wise. Our providers that come from communities that are underserved totally get it and understand access and know from the cycle of poverty how important social determinants of health are. And that includes prices, and that includes the cost of care. People, our communities, in our poor communities, are very proud and work hard and want to keep their families intact as long as they can. And for the patients that have the cancers and heart failures and complications of diabetes that really do need the best medicines possible to make life easier, not only for the patient, but for the families. To live longer without complications is so important to decrease the stress in our communities. And we have so much stress as it is. Why add more? And, healthcare is a personal issue, but it's also a family issue. And I remember talking about this with the COVID-19 and trying to get to our communities, and people in policy world just thought, oh, we just give it to the clinics or the hospitals. But wait a minute, we needed to get vans and mobile clinics to get mobile, vaccine health fairs in our communities. Well, this is the same thing with medications. We need medications that don't stay in the rich communities because people can't afford them. And we need to really focus on access to medications that work and that are, and we are in the 21st century, Gary. So yes, and I have to say that I think that the models that have been developed in our minority communities, the historically Black colleges, medical schools, they are so much, they're light years ahead of the Hispanic communities, the Native American communities that have little pockets of recruitment efforts. Our medical schools do what they can to increase the knowledge to the communities, but I think it's up to the communities and the professionals, the alumni, to be in more mentoring, and that's what we're doing with our National Hispanic Health Foundations, now an umbrella group with the National Hispanic Medical Association, nurses, dentists, pharmacists, and so many others that all want to develop our workforce and have an increased workforce in this country. And honestly, I think we should have the models of the HBCUs with the Latino medical school system that does not exist. And I know this federal government, another issue I have is that they've gotten rid of the grants to Hispanic serving institutions. I mean, that's rich. Anyway, I'm not even going to go there. but we definitely need a diverse workforce. We need more disabled, we need more women, we need more LGBT, we need more people of color that can take care of their own people in a better, more respectable way and understand why we need access to better medications and innovations.
You see, I'm so glad to bring this conversation to a close with you. I believe in the free market. I believe in business solutions. I think our healthcare system would benefit the most by backing government out of some of what's going on here. And I'm not trying to put words in your mouth, even though I'd love to recruit you into the cause, but I'd love to hear your closing thoughts.
Everything is, I mean, there's been great thought leadership here today. Thank you for having me again. I think, from my perspective, and I did spend time in healthcare. I worked for a large safety net hospital system. So I've been on pretty much all sides of the fence. But what I would say is I think that the business community does have a role to play here. And I don't know that there's enough connectivity that should be just a strategic part of any piece of advocacy. And I think that until it becomes personal, then, action doesn't necessarily, follow quickly. And everybody has a personal story of a lack of access, a family member, a neighbor, and so I think we need to be able to, be really good at storytelling and going to the pieces of the community in rural business community and telling them, this is personal to you. If it's not now, it will be. And there needs to be a framework that I believe we should make it easier for the business community to be able to plug in and lend their expertise, their influence to these discussions.
Again, I want to thank everyone for participating. I want to thank the panelists for a great conversation, and hopefully we've introduced you a little bit more to MFN and some of the challenges that lie therein. So thank you very much and have a great rest of your day. Thank you.